Welcome to Season 2 of Public Health on Call, a podcast from the Johns Hopkins Bloomberg School of Public Health. I'm Joshua Sharfstein, Vice Dean for Public Health Practice and Community Engagement, and a former Secretary of Maryland's Health Department. Our goal is to bring scientific evidence and experience to the public health news of the day through informative interviews with scientists, community leaders, policy experts, public health officials, clinicians, and more. If you have ideas or questions for us to cover, please email us at publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes. Today, as part of a periodic series on overdose and the pandemic, Johns Hopkins professor Susan Sherman speaks with Monique Tula, Executive Director of the National Harm Reduction Coalition, and Louise Vincent, Executive Director of the North Carolina Survivors Union and the Urban Survivors Union. They discuss the role of harm reduction in addressing both the COVID and the overdose crises. Let's listen.
I'm so thrilled to have two guests. The first is Monique Tula. She is the Executive Director of the National Harm Reduction Coalition, and also Louise Vincent. She is heads the North Carolina Survivors Union and Urban Survivors Union. And if you say name 5 activists around and advocates for people who use drugs in the U.S. who both are on the ground and translate into policy work as well, Louise would be one of the people that you would hear her name. So welcome to both of you. Thanks for being here today.
Thank you.
Thank you.
Monique, can you talk a little bit about HRC and what you do?
Yeah, so I'm Monique Tula. I'm the Executive Director of the National Harm Reduction Coalition. Our organization has been around for about 26 years. We provide training and technical assistance to community-based organizations and health departments and even municipal leaders on harm reduction itself, how to start up a syringe service program, what harm reduction is. We do a little bit of history. We make some connections between harm reduction and the drug war, which you can't untie anyway.
Louise, can you introduce yourself?
Sure. My name's Louise Vincent, and I'm the Executive Director of North Carolina Survivors Union, and I'm on the leadership team of Urban Survivors Union. Both groups are groups of people who are practicing harm reduction and activism. We're community organizers, really, and we are providing direct services as a way to engage people and to work with people who use drugs. So basically, we work with people who use drugs at every stage of the substance use continuum, which means we work with people who are in, chaotic use, and we work with people who use drugs, recreationally and, just all people really. But the big thing that we do is we try to engage people that use drugs in all of our work and really be the drug user voice. There are so many times we are talking about what drug users think, how drug users feel, what drug users need, and we don't have people who identify as drug users at the table. And so what these groups do is they are groups who are saying we are drug users and we want our voice heard, and this is what we think. And so we provide that.
That's great. Thank you. Monique, can you talk a little bit about harm reduction? What is it?
Sure. Well, harm reduction has its roots in this country in the HIV/AIDS epidemic, right? So it was a direct response to the lack of attention and political will that we needed to address the raging HIV epidemics among people who inject drugs. There are some essential tenets of harm reduction. So health and dignity, and to Louise's point, health and dignity is about, the right to be healthy and seen as a whole person. Participant-centered services, which is about meeting people where they are rather than where we want them to be. Participant involvement, again, looking back at what Louise just said, so both in the design and services and the ability to participate in advocacy, participant on autonomy, which is the right and ability to make your own choices. And harm reduction also understands the very real and potentially tragic harms that are sometimes associated with drug use, so we don't ignore or minimize them. But really, we think of it as one of the most effective and familiar. When I think about harm reduction, or when people talk about harm reduction, they often name syringe service programs, right? So in the 80s, those programs were established to prevent HIV transmission among people who inject drugs. And since then, they have become a primary point of care for a lot of folks, right? Where they can find, screening and treatment, but also linkages to shelter, housing services, maybe there's some primary health care, treatment. And I think most importantly, folks are seen without judgment, and that gives people an opportunity to develop relationships, right? And that relationship is really key because most people who use drugs experience stigma, distrust, fear, alienated, ostracized, right, from society. And nearly every day, a lot of folks who are using can be living in a state of emergency, right? So they may not have housing, stable housing, they might be criminalized, fear of incarceration, fear of overdose because the street drug supply has been poisoned by fentanyl. And, a lot of people who use drugs may have chronic medical conditions that are also risk factors for COVID, which I know we're going to talk about in a little bit. So again, more often than not, syringe service programs are the only place where a person who uses drugs can receive some services and make some contact with folks who care about their humanity and not judge them for their drug use.
One thing that you didn't mention when I think of harm reduction, it's crazy how radical it is to actually center people's lived experiences who are so disregarded and stigmatized. It sounds like such a simple thing, but it's really radical. And that to me speaks to also that it's a social movement and not just service delivery. So can you talk a little bit about harm reduction as a social movement, social justice movement?
When people think about harm reduction, they often think about syringe service programs, right? But really, it's much, much bigger than that. Our work is about protecting the rights and bodily autonomy of people who use drugs and beyond, right? Harm reduction, my belief is that harm reduction really has the potential to restore hope and healing. It's more than a public health strategy. It's a movement of people who are dedicated to shifting power and resources to people and communities that are vulnerable to structural violence.
Great, thank you. And maybe I can ask Louise this before you start talking about some other things. Why has harm reduction been so political in the U.S.? How is a service provision that's so effective in reaching people that some people could think they're so expensive, they tax the system, it's such a cost-effective way if you don't actually care about people, it even is financially smart. Why so political?
Well, I can't answer why we do what we do in the United States and why we can't see beyond. We struggle in all sorts of ways. We've struggled with condoms. We've struggled with, are we helping people use drugs? And these sort of questions of morality, right? And drugs hit all of those places where we think about morality. And I think that's a huge problem. For me, it should not be an issue, but I'm from North Carolina, right? And so everything that I grew up hearing contradicts what I believe now, right? So it was very hard for me early on to get on board with harm reduction because everything you hear about substance use is that you don't want to help a person. You need to not enable them and all these things. And harm reduction is so much about is so much about, all of these public health tools and all of these social justice tools that make sense. But we watched in North Carolina 20 years after syringe service programs were operating in other places, we did not have them. And we were actually watching people get sick with hepatitis C and watching people suffer needlessly when we had tools that could really improve their lives. And so I don't know why we have such a struggle, getting on board, but it's important that we do, because in what hangs in the balance is people's lives and tragedy, right? We don't have to have people suffering with HIV and hepatitis C and all of these society's ills when we have such simple and loving response that can really help people. So it's hard for me to understand.
You bring up the word love, and I think it's important to say it really is such an intense act of kindness to serve people, see them as they are, smell them as they are, hear them as they are, and accept them into programs without judgment. And that is different than a lot of programs that address, that are designed. Well, they're not designed with, but designed for people who use drugs that are often punitive and have a different notion. Like tough love looks very different than what we're talking about, I think. Why? So I want to think a little bit about, and asking you, Louise, how do you see harm reduction's relevance to reaching people in the time of COVID?
Well, I mean, absolutely necessary, right? So during the time of COVID, we've got a real crisis. We've got a crisis of a pandemic. We've got a crisis of people's distrust of our government, right? Which is what I see as a huge problem. So right now, drug users don't know who to talk to, right? So I have epidemiologists as friends and people I can call and people I can talk to and say, hey, what's going on? But your normal everyday drug user on the street doesn't have access to just loads of people they can call and find out what's really happening in the world. And so we have people that don't know what to believe about COVID, don't know what to think about all that's happening in the world, and then they can't protect themselves, right? So you've got two things going on. You can't protect yourself, and you don't know what the hell to think about what's happening anyway. And so those two really are the perfect storm for just saying, you know what? I'm not doing anything about this. I can't protect myself anyway, and I don't think it's really happening. And so what happens is people ignore it because what do you do? I mean, if you can't, and so what I see is, one, people not able to take care of themselves. And then we have agencies closing down and not providing good services, which is not acceptable. So at the Drug User Health Center that we run, we're doing more. We are, getting a heater to have outside. We are serving espresso and coffee since we can't hug you and hold you. We are making sure that our eyes and our, when we are talking to you, we are paying attention to you. And we're talking a lot about, making sure that we are engaging with people in different ways with body language and really digging deeper than we were before, right? Because we can't do the things that we know how to do. We have to step one step further and figure out how to do more. And that's why harm reduction is so essential in the time of COVID, because we're the only people that are going to do this, right? We are the ones that are saying this is an important population. This is an important group of people that's already suffering. We had an overdose crisis way before COVID, and we still have an overdose crisis. And in fact, the overdose crisis is getting worse. And we are going to see numbers like we've never seen. And I'm truly worried about it. And we are seeing people suffer, not able to get access to services they need. And then we see people isolated at home and not at home, or isolated in general. And it is, people are using more drugs than they've used. And so we're seeing people use more drugs. We're seeing people in more chaos. We're seeing people struggle with more depression and mental illness. All of these things are happening. And And the people that know how to engage with this population are harm reductionists. Bottom line, if you want to work with drug users, you're going to have to work with people that work with drug users and who are drug users. And we are harm reductionists, and we've been working with this population for a long time and doing a good job with it. And so when you need to, when you're in crisis or you have a community in crisis, you go to the people who know how to work with the community in crisis. And we have a community in crisis. And so we need to work with harm reductionists.
It's hard to imagine crisis on top of crisis. I mean, it's been such a crisis on the East Coast. You're in North Carolina. You have an adulterated drug supply there like we do with our powdered heroin, if there's heroin left. We're finding, fentanyls and all different types of drugs on the streets. So it's just unbelievable to think of like more fuel on the fire. Tell me something. How are, like you talked about, people are using more drugs. Has the drug market been impacted? And people, are you seeing more abscesses? Are you seeing more bad health outcomes related to people's drug use because the drugs have changed during COVID?
Absolutely. I mean, we are seeing a drug supply that's contaminated and it doesn't make any sense. So we're seeing very, very strong opiates, lots of cut in, and certainly a synthetic drug crisis, lots of synthetics, lots of drugs that we don't know what they are, lots of things that are called this but are really this, polysubstance use. So lots of people using lots of different things, and then no one able to go to the doctor, no one going to the doctor, abscesses, all sorts of skin infections. I'm truly concerned about the level of infections that we're seeing. And then people already scared to go to the hospital. And then they have rules where you have to be in the hospital alone. People can't come visit you. So nobody wants to go do that. We really do have a mess. And it's going to take a lot of effort to really help this population. I'm extremely worried about the things that I see day to day, and the drugs that we see, and how they're impacting people.
Have people had COVID? Have you seen COVID hit the populations with whom you work?
We have not seen a lot of people that use our services get COVID. This is just starting. So just this week, we heard that some people that we were engaged with had COVID. And so now we're trying to figure out who needs to quarantine, how does this work? So this is the first time that I've ever had to deal with whether I need to quarantine because I was around somebody who was around somebody. And so these things are just now impacting us. And I, early on in the crisis in New York, we didn't see very much happening in North Carolina, but now we are starting to see this happen in North Carolina. And I'm very concerned that once we start seeing it happen, it's not going to stop happening. Right. So that's my concern. I have always been worried that once it starts, it's going to be devastating.
And I don't mean to say that the only impact of COVID is if people have it directly themselves, because obviously you just talked about a changed service landscape and the changed drug supply. And so how it affects the environment in which people live has huge impact, even if they're not touched themselves by it. That's a way of being touched by it. Monique, can you talk a little bit about kind of nationally from where you sit, what you know about what organizations are out there doing? A lot of health departments have scaled back services and harm reduction services have stepped in with not more resources. What kinds of innovation, what kinds of things have you seen during this time with organizations' response to the threats of COVID and impact on people who use drugs?
Right. So there was a study that was conducted. It was really a collaborative effort between a few different entities where they surveyed over 170 syringe service programs around the country, right? And so they were asked about how COVID was impacting their ability to serve program participants. So in the first month of COVID, there was about 43% of syringe service programs that responded were operating at a reduced capacity, and about 25% reported that they had closed one or more of the sites. And also at that time, about a third were beginning to screen program participants for COVID. Half of the organizations were pre-packing supplies. Some were providing delivery services, right? So using vans or outreach to get supplies to folks. They were mailing supplies to program participants. But, again, imagine trying to mail something to a person who doesn't have stable housing, right? Super problematic. The other thing that came up is that although we know that syringe service programs are an essential service, that's not always recognized by, some jurisdictions, right? And so nearly all of the respondents in that survey noted that policymakers and leaders didn't include syringe service programs in their jurisdictional emergency planning and response. And that is essentially the erasure of people who use drugs. But despite that erasure, the demand is still high, right? And, the staff, I'm really concerned about staff in syringe service programs that have remained opened. They've adapted, right, to maximize safety for both program participants and staff by reinforcing social distancing, minimizing the number of visits, giving people more supplies, so increasing the quantity of supplies given in like a single instance. I'm concerned about program participants. I'm concerned about staff of syringe service programs. At what point are we gonna, is there ever gonna be an after COVID, right? Do we revert? And there's actually been a little bit of progress because of COVID, right? So we saw some relaxing of the regulations, right? Around medication for opioid use disorder or MOUD. There were really unreasonable limits, right, on those prescribing practices, and that were structural barriers to bringing those to scale. But the federal limits on prescribing for buprenorphine have relaxed for COVID, although people in rural areas or people who don't have transportation are still vulnerable. But what happens to those regulations after COVID, if there is an after COVID? Do we revert back? Yeah, it's unclear to me what happens. And, the AMA just updated a report that they published in October that shows this correlation between COVID and overdose. And in that report, it says that 40 different states that are reporting increases, along with growing concerns about upticks in substance use, mental health issues. There was in Virginia, there was an emergency room in Virginia that reported between March and June of 2019, right, there was about 102 incidences of overdoses, right, that had come in. And in that same period this year, there were, more than double the number of cases. The other thing that I want to point out is that in Virginia, compared to 2019, in 2020, people with an opioid-related overdose were more likely to be Black. So there are noticeable disparities in COVID-19 cases and deaths by race, socioeconomic status, where you live. Areas with more poverty and more Black and brown people are showing to have a higher burden of COVID cases and deaths.
Thank you. And of course, that falls, COVID follows where opioid overdoses follow and other overdoses just overdose. So sadly, people are continuously to be disproportionately burdened. I think that's true. Something that's really interesting is not only has COVID impacted and driven the loosening of SAMHSA's regulations around medications for opioid use disorder, but also there have been movements, and in cities there have been pushes to reduce arrests for low-level drug offenses. So this could be the first thing to go potentially when we live post-COVID, if there is post-COVID, without evidence showing that it's important, and there are really bad outcomes when you arrest people for low-level drug offenses, which we know. But this is this epidemic, COVID epidemic, has actually pushed some good drug policy through. And I just was wondering your thoughts about that.
I don't know. That's a tough one because, to be honest with you, the relaxing of those regulations are the only thing that I'm seeing that is directly tied to COVID. So I think that's where I just got stuck a little bit. I think that there's other things that are, causing us to think differently about drug use and substance use disorder.
It occurs to me that these changes, if they are not permanent, and if they have not changed the way we think about substance use fundamentally, right? So if we are only doing this because, we can't deal with the impact of COVID on the jail, or we are only doing this because we don't want to get sued for people coming into, MAT programs and getting sick. If we are only doing it for those reasons, and we don't have a fundamental restructuring and understanding of substance use and the way it impacts human lives and the way it impacts people, then COVID has done nothing to actually shift and change anything in the long term. And that's not useful. So if it has brought fundamental change, and we are actually seeing, there's a reason we don't need to be putting people, in prison, in these huge amounts. And there's all of these things, and the bottom didn't fall out when we gave people take homes, and and life didn't come to a screeching halt. Possibly we can learn some things, and that can impact what we do in the future. But what I do understand is we need a fundamental restructuring and understanding of the way we see substance use and the way substance use impacts human lives and the way we treat people who use drugs. And I have not seen COVID shift the way we feel about people who use drugs, because we are still allowing people who use drugs to die at rates that are unacceptable. And we are still not giving voice to people who are in prison and who are suffering and at high risk of COVID unnecessarily.
Yeah, I would add that, this, if you want to call it a syndemic, right? The COVID-19, the overdose epidemic, and then you add like the uprisings, the polarity of the country in this moment. And the amount of trauma that all of that causes at the individual, to the individual, right? But we're also experiencing it collectively, right? We are witnessing the transformation of our world. We're entering this new phase, and we don't have the tools to navigate it very well. We're collectively trying to find our way to the new normal, which we have no idea what that's looking like, and simultaneously trying to cope, and process and learn how to respond to everything that's going on around us. The policies that formed that are the foundation of the war on drugs are rooted in this like a dying paradigm, right? That has been fueled by capitalism, interdiction, and really white supremacy. I
was going to say racism, but yeah.
I mean, and they're misguided policies, that work against connection. There's only serve to perpetuate harm to the very people that they're supposed to help. So we need a different kind of consciousness. The level of consciousness that gave rise to the war on drugs it's rooted in stigma and racism and patriarchal superiority, right? So that level of human consciousness cannot solve the war on drugs, and it won't solve COVID-19, and it won't solve white supremacy or institutional racism. We need a whole different way of thinking.
The last thing I want to ask you all is, where is there hope? Where's the hope in, I always, it's so interesting. Harm reduction really was co-opted in a lot of ways during the opioid epidemic. People called themselves harm reductionist, or organizations were popping up all over the place that were called harm reduction that really didn't hold those central tenets of treating people with dignity and respect, and involving like lifting the voices, structuring organizations to really lift the voices and give people who use drugs the tools to be a part of the process. So how do you feel that in this time of COVID, yet another crisis in the midst of the overdose crisis, how do you feel harm reduction, where's the hope, and how can harm reduction stay true to itself?
I mean, that's a good one. I think that it is a setup to expect harm reduction to stay, to operate as a grassroots, radical grassroots movement. I think we are beyond that. And those of us who have been harm reductionists for some number of years, many years, those of us who are kind of clinging to that ideology I think that we're sort of fooling ourselves. And I know a lot of people disagree with me on this. There was, my dear friend, I say this all the time, my dear friend Eliza Wheeler and I were talking about avant-garde, right? The avant-garde. And she was saying that really, like, any avant-garde movement, like, will eventually, like, if it's, will become mainstream. Not all of them, but eventually they do. And the tension that arises is, between like wanting to hold on, to what things used to be, and and then what are we willing to let go of? Right. Do you want to jump in, Louise?
Well, I think that there's something wonderful about there's something powerful about harm reduction becoming mainstream, right? And that is that it's mainstream. That is that it's not so radical to talk about showing people dignity and respect, but you do lose the radical fire. You do lose you lose some of the power that is so special, right? But that's the fight to get it to be mainstream, right? I think there is something that we have to be, I don't think we'd be in the position we are today if we weren't doing that, where we have grants that are able to come from more mainstream organizations to support drug user-led harm reduction organizations. I mean, that is something that wouldn't have happened in a very early grassroots movement that we're seeing now. So those are the benefits of harm reduction being more mainstream and people recognizing that it has power and that it works, right? And so that's what we want. But what we don't want is to lose the beauty of harm reduction and it become a public health intervention, right? It can't just be a public health intervention and lose the social justice and the big H, the big R, the human rights, if it loses that, that's not about being radical and grassroots. That's about losing part of the movement. That's about pulling out the part that's the public health intervention and leaving the part that's about social justice behind. And you can't do that because that's not what harm reduction is. Harm reduction is all of that. And if you don't take all of that with it, then you just have a syringe service intervention, which is not near as powerful as a human rights, movement with with some public health interventions held within it. So I think that there's real power in becoming mainstream. I think there's nothing wrong with that. I think there's nothing wrong. In fact, it's good, right? We want mainstream. I want, when drug users seek help, I want them to receive harm reduction services every single time. That would be ideal. I just want them to receive the harm reduction services that encompass all of those things I talked about.
At its core, harm reduction is about radical love. And it recognizes the interconnection that we all have, right? Harm to one of us is harm to all of us. That's what we don't want to lose. That's the radical part of harm reduction. Everything else, to Louise's point, is, policy and advocacy strategy or public health. At its core, it's about treating people differently. And as we're navigating this new volatile world that we're in, I think that, we have to remember that it's not just about public health. It's not just about changing policy. Policies are only as good as the people who practice them. It's the quality of our interactions that need to change, right? So what harm reduction does when conflict presents itself, harm reduction demands that we pause, before our judging mind takes over, and ask ourselves, what is the most loving thing that I can do right now? I really believe that that's the essence of harm reduction and why so many of us, consider it a way of life. It's radical love. It's liberation from old ways of thinking and doing. And isn't that what this moment is demanding of us all? Liberation, right? From centuries of oppression. We human beings often don't evolve until we're in a state of crisis.
Right.
And we're there now, right? And it may continue. It might get worse.
Something that COVID really emphasizes is the connectedness of all of us. So many people want to put blinders on. They don't want to look at the people who live at the margins. They don't look down to see who happens to be sitting on the ground when they walk by or think about them as a human being. But COVID forces us to understand the connectedness. You are connected to the person who delivers your Amazon packages, or you are connected to the guy that's in your yard in a way that actually could even transmit disease in one way or the other. And so I think that if we don't look at the positive aspect of that connection, and it's really hard in an epidemic that isolation is a way you don't get sick. It is a moment of really understanding. And I think harm reduction at its core, the radical love, is about connection and about seeing people. So hopefully this will be a time that our movement can thrive, and people, it is hard to know what the other side of this and where the hope is with so many lives that eventually will be lost. But I think there's a hope in trying to really maximize the love around that connection.
This movement has saved many of our lives. It has saved many, has given us a reason to live again, has given us a reason to continue forward when we couldn't find a way. And so I hope that it is that sort of resilience and that sort of, that we've put enough in, right? That we've put enough in that it will pull us together, and that the distance and the struggle won't be, and the isolation won't pull us all apart. But my hope is very much that we've put enough in, and that there's enough love in here that we can pull through.
Thank you all.
I love that reframe.
I love that reframe, true. And, a word that comes to mind as you were talking, Louise, is resilience. Like, it's a resilient movement, and these times definitely necessitate resiliency. So thank you both so much for spending time today. I know people are going to enjoy listening to you and your wisdom, so thank you.
Public Health on Call is produced by Joshua Sharfstein, Lindsay Smith-Rogers, Stephanie Desmond, and Lamari Morales. Audio production by Spencer Greer, Niall Owen McCusker, Cian Oates, and Matthew Martin, with support from Chip Hickey. Distribution by Nick Moran. Thank you for listening.